Complication of third stage of labor. Human placenta features decidua, discoid, and hemocoel. Most important factor for placental separation, uterine contraction. Place of separation, zona spongiosa. Retained placenta and placenta accreta spectrum. Retained placenta. Placenta does not deliver in more than 30 minutes after delivery of baby, also known as prolonged third stage of labor. Causes and management. Based on cause, placenta separated from uterus but not expelled. Signs of separation present plus trapped placenta. Management: empty patient's bladder per abdominal examination. Uterus relaxed. Oxytocin plus control cord traction. If cord breaks, manual removal of placenta under short general anesthesia. Uterus relaxed and internal os closed. Manual removal of placenta under short general anesthesia. Placenta attached to uterus but doesn't invade myometrium. Oxytocin plus control cord traction. If no response, manual removal of placenta under general anesthesia. Placenta invades myometrium, morbidly adherent. Placenta accreta spectrum, hysterectomy. Placenta accreta spectrum types: uterovesicular fold, normal placenta, placenta accreta, most common chorionic villi superficially attached to myometrium. Placenta increta, chorionic villi invades into myometrium. Placenta percreta, chorionic villi attached to serosa. Endometrium, myometrium, serosa. Risk factors: placenta previa in current pregnancy. Past history of C-section, most important, dilatation and curettage, myomectomy. Etiology: absent Nitabuch layer. Defective decidua basalis. Investigation: ultrasound with Doppler, investigation of choice. Heterogeneous placenta, northeastern placenta, placental lakes. Loss of hypoechoic area below placenta, absent decidua basalis. White line of bladder serosa interface interrupted. Management: hysterectomy. Uterine inversion. Prolapse of uterus into uterine cavity. Uterine inversion versus uterine prolapse. Uterine inversion, os not seen. Uterine prolapse, os seen. Classification. Acute. So we are talking about uterine inversion, which is further classified into acute, subacute, and chronic, as if acute and chronic were not enough to remember. So acute is less than 24 hours, subacute is 24 hours to 4 weeks, and more than 4 weeks, that is 1 month, is chronic. Based on extent of inversion: first degree, second degree, third degree, fourth degree. First degree, uterine fundus descend into uterine cavity but not protrude out of os. Second degree, uterine fundus reaches the level of the os but does not protrude out. Uterine fundus protrude out of the introitus. Complete inversion of uterus and vagina, that is fourth degree. Causes: most chronic is iatrogenic, mismanaged third stage of labor. Clinical feature: shock immediately after post-delivery. Initial shock neurogenic due to stretching of parasympathetic nerves, consequently hemorrhage is the cause of death. On examination: cup-like depression below umbilicus or pervaginal globular structure in vagina. Uterus fundus is not palpable. Note: shock immediately after birth, plus out of proportional to blood loss, then uterine inversion is suspected. Management: call for help plus resuscitate patient. Stop uterotonics, oxytocin. Manual replacement of uterus, Johnson's method. Principle: first part to prolapse, last part to redeposited. Do not separate placenta, increased risk of hemorrhage. Fails, repeat manual replacement under general anesthesia, uterine relaxant, terbutaline. Fails, abdominal surgery, Huntington's method. Surgery, Huntington's method. Outdated methods are as below. Another surgery that's performed is Holton's method if constriction present. Constriction ring incised. Outdated method is hydrostatic O'Sullivan's method. Vaginal surgeries, Spinelli method. Cascardix surgery. Post replacement management: stop uterine relaxant, remove placenta, start oxytocin, start antibiotics. Amniotic fluid embolism, that is another complication. Early entry of amniotic fluid into maternal circulation, also known as anaphylactoid syndrome of pregnancy. Catastrophic obstetric emergency, incidence 1 in 100,000 deliveries. Pathophysiology: erratic uterine contraction, breach in maternal fetal interface and opening of venous sinuses. Amniotic fluid containing fetal skin, debris and antigens enter maternal circulation. Enters pulmonary circulation. Respiratory symptoms due to pulmonary embolism. Pathognomic: activation of factor 5, 6, 7. So activation of factor 7 and plasminogen, disseminated intravascular coagulation. Activation of immunological reaction plus systemic inflammatory response. Clinical features: phase 1, during labor, less than 30 minutes of delivery. Respiratory depression plus unexplained shock plus minimal bleeding. Complaint of breathlessness, SpO2 less than 60%. Hypoxia plus metabolic acidosis. Phase 2, disseminated intravascular coagulation, excessive bleeding. Diagnosis: clinical criteria: unexplained shock with minimum bleeding. Clinical onset of shock within 30 minutes of labor. Absent cardiopulmonary arrest, complaint of breathlessness and shock. Overt DIC, no fever. Pulmonary vessel catheterization. Management: ICU management, increased maternal mortality. Postpartum collapse diagnosis: appearance of symptoms and when they appear, what are the symptoms, what is per abdominal examination and per vaginal examination in postpartum collapse. 3 reasons: postpartum hemorrhage, uterine inversion, amniotic fluid embolism. Postpartum hemorrhage and uterine inversion happens within 24 hours of delivery, patient will collapse. In amniotic fluid, within 30 minutes of delivery, patient will collapse. Symptoms: postpartum hemorrhage, there will be excessive bleeding. Most common cause of postpartum collapse is postpartum hemorrhage. Uterine inversion, immediate shock after delivery plus minimal bleeding initially. So when the symptoms are out of proportional of the blood loss, then you suspect uterine inversion. Fluid embolism, first phase is respiratory difficulty plus shock plus minimum bleeding. Respiratory difficulty is pathognomic. Second phase is TIC, increased bleeding. So first phase minimum bleeding followed by second phase increased bleeding. Per abdominal examination, you see tone of uterus is decreased in postpartum hemorrhage, cup-like depression below umbilicus in uterine inversion, and everything's normal on per abdominal amniotic fluid embolism. Per vaginal examination, you see increased blood loss in postpartum hemorrhage, globular structure inside vagina in uterine inversion, and everything is normal in amniotic fluid embolism.